चाहिए। हेलो, हाँ अब आ रहा है ना, आएगा। हेलो हेलो, अब आएगा। हेलो 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 हेलो, अब आएगा। आ गया। हेलो, हाँ अब आ रहा है ना। हेलो हेलो, हेलो हेलो हेलो। शूट यहाँ रख के जा रहा हूँ, उस पर साइन।
Good afternoon, everyone. My name is Dr. Keshav Agarwal, and today I'll be discussing the topic fluid responsiveness. I'm a junior resident in the Department of Surgical Disciplines at AIIMS, New Delhi. So today we'll be discussing this topic under the following headings. First of all, what is the physiology of fluid responsiveness? What and when are the situations that we need to apply this fluid responsiveness to? What are the various fluids that can be used for such resuscitation? And how do we assess or monitor the response to fluid? And what are finally the endpoints of resuscitation? So first of all, coming to the physiology of fluid responsiveness. According to the Frank-Starling law, it is seen that as the cardiac preload increases, we have increase in the stroke volume. So what is the mechanism behind this? As the cardiac preload increases, it leads to increase in left ventricular end diastolic volume. So the increase in left ventricular end diastolic volume leads to stretching of the myocardial fibers. As the myocardial fibers get stretched, more and more actin and myosin filaments get engaged, and it leads to a stronger contraction from the cardiac muscle, which leads to increase in stroke volume. Now this happens up to a particular point, beyond which the curve gets flattened. As in accordance with the length-tension relationship, if there is excessive stretching of the myocardial fibers, then it decreases the interaction between actin and myosin filaments, and which finally leads to decrease in stroke volume. Also important regarding the physiology of fluid responsiveness is venous return. Now the venous return depends on three factors: the mean systemic filling pressure, the right atrial pressure, and the resistance to venous flow. And it can be seen from this equation that the venous return is equal to mean systemic filling pressure minus the right atrial pressure divided by the resistance to venous flow. So this is a linear relationship between the venous return and the above three factors. And if we plot them on a diagram, it can be seen from here that as the right atrial pressure decreases, it leads to increase in venous return up to a level which is known as critical pressure. Now this critical pressure is the pressure at which if the pressure decreases beyond the critical pressure, then the veins get collapsed. And if the veins get collapsed, the resistance increases. So there is no further increase in venous return from our side. However, it can be seen also from this diagram that if there is increased mean systemic filling pressure, as can be seen from this curve to this curve, then it leads to further increase in venous return. Also, by decreasing the resistance of the veins, it has been seen that there is increase in venous return. Now, what if when we combine the above two mentioned curves? Now, if we combine the Frank-Starling and the venous return curves, here we have shown three curves depicting the various cardiac function. This is the normal cardiac function. This is the increased cardiac function, as can be seen in cases of further inotropic support. And this is a curve with a poor cardiac function, as can be seen in, for example, cases of congestive cardiac failure. So in this case, when we combine the venous return and the cardiac output curves, let us see what happens. So when we increase the mean systemic filling pressure from 0.1 to 0.2 on the cardiac curve with a poor function, we can see that there is not significant increase in the respective stroke volume. So as is exemplified in this, so giving the further fluid to this patient does not lead to increase in stroke output, and this is characterized as fluid unresponsiveness. So what do we do in such a case scenario with poor cardiac function? When we provide the patient with inotropic support leads to shifting of the curve towards the left and shifting of the patient from point 1 to point 3. So it can be seen that for a specific mean systemic filling pressure, increase in cardiac function leads to further increase in stroke volume and therefore improvement in tissue perfusion. However, if we provide excessive inotropic support to the patient, as can be seen in shifting the curve to excessive left side, then the cardiac output does not increase. So excessive inotropic support can be even in fact harmful to the patient because it increases the oxygen requirement of the heart, whereas it does not increase the cardiac output. However, providing both the cardiac support as well as venous filling leads to shifting of the patient from point 3 to point 5. So this shifting leads to increase in stroke volume, which further helps the patient to maintain the tissue perfusion. So what are the consequences of tissue hyperperfusion? Prolonged tissue hyperperfusion, irrespective of whether it is due to blood loss or vasoconstriction, leads to anaerobic metabolism. And anaerobic metabolism leads to generation of products like lactic acid. Now lactic acid accumulation leads to metabolic acidosis. Metabolic acidosis in turn leads to poor enzyme function and poor function of the organ, which in case of heart can lead to bradycardia, decreased cardiac output, dysrhythmias, hypotension, etc., which in turn perpetuates the cycle again of tissue hyperperfusion, again further leading to a vicious cycle. Now, when do we need to assess the fluid responsiveness? What are the various situations? Now, with respect to surgical patient, the various situations that are encountered for resuscitation are in the management of shock, which can be hemorrhagic, cardiogenic, septic, neurogenic. Regarding the preoperative optimization, especially in emergency surgical conditions, and in cases of postoperative optimization. And what are the various fluids that are present in the armamentarium of the surgeon? These are crystalloids, colloids, blood and blood products. So, which type of fluid should we choose for resuscitation? It depends on the type and the volume of the loss, and usually crystalloids are the fluid of choice, and the various crystalloids are normal saline, ringal lactate and plasmalide. However, colloids can also be chosen, which include albumin, gelatin, dextran and starches. However, these are not preferred because it has been shown by various studies, for example a study conducted by Boone et al. In the Cochrane Database Review in 2012, that colloids are not superior in efficacy and safety as compared to crystalloid, and they can have various side effects like risk for anaphylaxis, coagulation abnormalities in case of dextran and HETA starches, as well as they are more expensive as compared to crystalloid. Also, it has been shown in the studies that of crystalloids versus colloids conducted in surgical patients by the published in the British Journal of Anesthesia by Larson et al. And Yates et al. With respect to the efficacy of crystalloids versus colloids, that colloids are not superior to crystalloids in terms of efficacy. Coming on to blood and blood products, they are considered as the best volume expander, especially in cases of blood loss. And the indications for blood and blood product transfusion include ongoing bleeding, anemia related to the acute blood loss, reversal of coagulopathy, thrombocytopenia. Now, in cases of acute trauma, wherein usually hypovolemia is due to hemorrhagic shock, when the patient initially presents after ensuring adequacy of the airway as well as ensuring adequate ventilation, we initially resuscitate the patient with 1 to 2 liter of warm saline, followed by requirement of uncross-matched blood, which is in accordance with the advanced trauma and life support guidelines. And if more and more blood loss is there, then we have to even transfuse cross-matched blood. And the massive transfusion protocol indicates that the ratio of the various components of blood, which include FFP, platelet and PRBC, should be 1:1:1, which has been supported by proper and PROMET studies that this ratio has the maximum advantage with reduced 6-day and 30-day mortality as compared to ratio of 1:1:2 of FFP, platelet and PRBC. Now, how do we assess fluid loss? What is the amount of fluid loss that the patient has encountered? So in order to assess fluid loss, what are the various parameters that we need to see are the sensorium of the patient, the general appearance, which includes with the presence of any severe thirst, dry mucous membrane, sunken eyes, reduced skin turgor. In sensorium, the patient becomes more and more disoriented with loss of cerebral perfusion. The pulse rate of the patient, whether the patient is tachycardic, bradycardic. The blood pressure of the patient, which usually in cases of hypovolemia falls. The urine output of the patient, which is a marker of renal perfusion, and the hematocrit. Now, even the ATLS has classified in cases of hemorrhagic shock, it has classified hemorrhagic shock into various grades in order to estimate the amount of blood loss that is encountered. Now, these are with respect to an average 70 kg man. So, in case of class 1 shock, a blood loss of up to 750 ml is encountered. In case of class 2 shock, about 750 to 1500 ml of blood loss is encountered. In case of class 3 shock, 1500 to 2000 ml of blood loss is encountered, and in case of class 4 shock, more than 2 liter of blood loss is encountered. And as we can see from here also, that the various parameters assessed are blood pressure, the pulse pressure, the urine output of the patient, and central nervous system or mental status. And we can see as the class progresses, there is progressive deterioration of the variables with the appearance of tachycardia in class 2, with the drop in BP with class 3, and the urine output becoming negligible and the patient becoming confused and lethargic with class 4. So how do we assess the fluid responsiveness? So once we have estimated the amount of blood loss or the fluid loss encountered, how do we assess the fluid responsiveness? So first, when the patient presents, we estimate the amount of fluid loss that the patient has encountered. Then after ensuring the patent airway and adequate ventilation, we start the resuscitation of patient with 1 to 2 liter of warm saline initially as a bolus over about 15 to 20 minutes. And then we assess the responsiveness to that fluid. So the various parameters used to assess the fluid responsiveness include the blood pressure of the patient, the sensorium of the patient, the urine output, the central venous pressure. Now, in case of central venous pressure specifically, we need to assess the dynamic response. So how do we assess the dynamic response is that we provide the patient with a bolus of about 150 to 200 ml of saline over 5 to 10 minutes, and we see whether the central venous pressure rises by 2 to 5 centimeter of water, which is considered as an adequate venous response. However, if the venous pressure does not rise by this, it indicates that the veins are empty and more fluid needs to be given to the patient. A high amount of rise indicates that the patient is already hypovolemic and the amount of resuscitation needs to be reduced. Base deficit and serum lactate, which I will be discussing subsequently. Now, the various other modalities which are less used and which are more invasive include invasive blood pressure, mixed venous oxygen saturation, cardiac output, and specific organ perfusion parameters. Like for example, in the case of gut, the gut mucosal pH, the sublingual capnometry. In case of muscle, the near infrared spectroscopy and the tissue oxygen electrodes. So when we consider serum lactate and base deficit, these are both are markers of systemic perfusion. And as we have already discussed, that lactate is an end product of anaerobic glycolysis. Whenever there is tissue hyperperfusion, it activates anaerobic glycolysis, which in turn leads to production of lactate. The normal lactate level concentration is less than 2 millimoles per liter. However, a concentration of more than 2 millimole per liter can indicate tissue hyperperfusion, and levels of more than 4 millimole per liter are associated with increased mortality. Base deficit, which is defined as the amount in millimoles of base that must be added to 1 liter of blood to raise the pH to 7.4 at a PeCO2 of 40 millimeter of mercury. Also the normal arterial base deficit is again less than 2 millimole per liter, and it has been graded into mild, moderate and severe depending on the amount of base deficit, which includes 2 to 5 millimole per liter categorized as mild base deficit, moderate base deficit are 6 to 14 millimole per liter, and severe base deficit is more than 15 millimole per liter. Now both of these markers, serum lactate and base deficit, can be evaluated with the help of arterial blood gas analysis, and both are relatively equal in efficacy when considering as markers of systemic perfusion. Mixed venous oxygen saturation is the percentage saturation of the oxygen returning to the heart from the body, and it is measured with the help of a central line. Now the normal value of this is around 50 to 70%. However, levels below 50% indicate that there is inadequate oxygen delivery and increased oxygen extraction by the tissue, which is prevalent in cases of hypovolemic or cardiogenic shock. Levels above 70% are seen in sepsis and some other forms of distributive shock. Now, what are the various endpoints of fluid resuscitation? When we consider the endpoints of fluid resuscitation, we have to consider the goal of optimal tissue perfusion. And for achieving this, we usually have to have a mean arterial pressure of about 60 to 65 millimeter of mercury, a urine output of at least 0.5 ml per kg per hour, a hemoglobin level of 7 to 9 gram per deciliter, which varies from case to case. For example, in critical care, a lower hemoglobin level of 7 is sufficient. pH value of 7.35 to 7.45. We have to consider the normal lactate levels. Achieve normal lactate levels, the base deficit, and the systemic mixed venous oxygen saturation. Core temperature of greater than 35 degrees Celsius. However, we should always remember that no single data point or lab value is sufficient to identify whether the patient has been adequately resuscitated or not. Now let us discuss a case scenario of a 51-year-old male presenting to the casualty with complaints of severe pain abdomen for the past 2 days. This pain abdomen is associated with abdominal distension, vomiting, and inability to pass stool and flatus. Patient has history of ATT intake for cervical tubercular lymphadenopathy for the past 6 months, and he has no other comorbidities or history of any previous surgery. Patient on examination was disoriented and was tachycardic with a pulse rate of 122 per minute and had BP of 80 by 54 millimeter of mercury. Mucous membranes of the patient were dry with cold clammy extremities. On per abdominal examination, abdomen was found to be tense and tender with guarding was present all over the abdomen and bubble sounds were absent. A chest X-ray was done which showed multiple air fluid levels along with air under the diaphragm. Now this case scenario is one of the common case scenarios that is encountered in the emergency, and it presents a suspicion of and it is a case of perforation peritonitis with secondary to most likely abdominal tuberculosis. So how do we proceed in this case? First, we carry out the investigations of the patient, CBC, RFT, LFT, and the serum electrolytes, as well as we secured 2 large IV bore cannula of 16 to 18 gauge and catheterized the patient as well as put a Ryle's tube. Plus, after securing the 2 large IV bore cannula, once we have ensured adequate patent airway as well as adequate ventilation, we start the patient on IV fluids and antibiotics. So we did send the investigations of the patient, and it was shown to have a normal hemoglobin with an elevated count of 15,215 and an elevated creatinine of 1.3. Patient's ABG was done which showed pH of 7.32, PCO2 of 34, bicarbonate of 16 and a lactate of 2.5. Now the patient has from this pattern metabolic acidosis and has an elevated lactate, which here is a marker of inadequate tissue perfusion. A Ryle's tube was inserted for the patient which drained 300 ml of biostat, and on catheterizing the patient 100 ml of urine was drained stat, and the urine was found to be concentrated with dark yellow color. So should we shift the patient directly to surgery or should we carry out preoperative resuscitation? No, we should first carry out preoperative resuscitation for the patient, because preoperative resuscitation is the key to intraoperative and postoperative recovery. So the initial management of this patient is that first, as we follow in each protocol, that patient's airway and breathing should be secured by providing oxygen by mask. We should ensure adequate circulation. How? By securing 2 large IV bore cannulas and starting the patient on an initial bolus of 1 to 2 liters of normal saline over 15 to 20 minutes, which should be preferably warm in order to prevent hypothermia to the patient. And then following the initial management, we assess the patient's response by the parameters that I have already described. Now following this initial bolus, the patient may improve. If the patient improves on this bolus, then we can start the patient on maintenance fluids, and then we can take the patient subsequently for operative exploration. However, if the patient does not improve, then the patient might have an inadequate resuscitation, or might have a cardiogenic component contributing to the shock, or a patient might be in septic shock. Now, how to assess for these is that first we see the patient's extremities. Even after providing the patient with 1 to 2 liter of bolus saline, if the patient's extremities still remain cold and clammy, then we need to assess the jugular venous pressure of the patient as well as the lung fields of the patient, whether there are presence of any crackles or not. So if the lung fields of the patient are clear and the jugular venous pressure is low, we might have even to require a central line insertion in order to assess the central venous pressure of the patient. So if the lung fields are clear and the jugular venous pressure is low, that indicates that the patient's heart is empty and we need to provide more fluid, which is that the patient is inadequately resuscitated. However, if the patient has high jugular venous pressure or central venous pressure, and the patient has crepitations on auscultation of the lung, then it indicates that the heart is full and the patient has a cardiogenic component to this. So the patient might require an inotropic support and even evaluation for myocardial ischemia. However, after the initial bolus, if the patient extremities become warm with bounding pulses, then it is an indicator of septic shock, and after starting the patient on IV antibiotics and initial resuscitation, we should have to take the patient expeditiously to operative exploration. So following resuscitation and before surgery, we need to have a pulse rate. So in order to have adequate resuscitation and prepare the patient for operative exploration, which should be urgent, we should have a pulse of less than 100 per minute, a systolic BP of more than 90 millimeter of mercury, or a mean arterial pressure of more than 65 millimeter of mercury. We should ensure adequate urine output of more than 0.5 ml per kg per hour with good capillary venous return. The sensorium of the patient may or may not improve. However, these parameters are more important, and patient should have a normal pH of 7.35 to 7.45. So that is how we resuscitate a patient, and these are the various parameters that we use in order to assess the fluid responsiveness of the patient. Thank you.
हो गया सर? हाँ तो सर साइन कर दें। थैंक यू सर। डिस्कनेक्ट कर दूँ सर?
कितने मिनट का होगा?
इसमें सर किसी ने चेक कमेंट्स तो लिखे ही नहीं है। मिनट्स तो सर ये 30 मिनट्स हैं।
ठीक।